Start grand rounds. Good morning, everybody. Start grand rounds. Today, we're going to hear about eczema, severe eczema, and some of the new therapies that are available for management. We're going to hear from Hana Tartibi, one of the Allergy Immunology Fellows, and Dr. Sami Bahna, who is chief of the section. So we'll go ahead and turn it over to you guys.
Hi. Good morning, everyone. So I'm going to just start by going over some of basic overviews of atopic dermatitis, and then Dr. Bahna is going to kind of go into more detail about the specific therapies. And so today we're going to be talking about the clinical features and stages of atopic derm, why it's important to us, the pathogenesis, the role of allergy, where we would come in more, as well as fundamentals of treatment, differentials to consider, and then eczema action plans and wet wrap dressings. So when you think of atopic dermatitis, you want to think about a chronic pruritic inflammatory skin disease. Usually you'll see it starting by 3 to 6 months of age, and in 90% of the cases they start before 5 years of age. And then most of these kids get better by adulthood. 40% of them clear it completely, and even those that don't clear completely, they tend to get less severe as time goes on. It's more common in urban areas, industrialized countries like our own, cooler temperate areas, and then in atopic families, bottle-fed infants, and then those children with early introduction of solid foods. Some of the major features is pruritus. This is one that we'd be battling a lot with our kids just to make them more comfortable, to be itching less. When they're younger, as infants and young children, they'll have more facial and extensor involvement, and then you'll see over time it'll evolve, and then now you'll have flexure-like magnification in adults. It's a chronic and relapsing dermatitis, so a lot of times they'll be like, it got better and then it got worse again, and that's just the nature of the disease, unfortunately. And there's always an atopic, not always, but there's more likely to be an atopic history in the family or the person themselves. The minor features is xerosis, or just extremely dry skin, cutaneous infections, they'll have nonspecific dermatitis of their hands or feet, and then you'll see sometimes anterior subcapsular cataracts, which is different than the posterior cataracts that they would get with chronic steroid use, so it's something to keep in mind. These kids or patients will commonly have elevated IgEs and positive skin prick tests. So some predisposing factors, we already went over some of these, but just to keep in mind also male gender makes them predisposed to developing AD. There's different stages in patients, and you'll see these commonly overlap in different patients, and so you'll have the acute stage where they're very pruritic, they have these erythematous papules, excoriations, and exudate. And then subacute, where it's just kind of smoldering, it's not quite as angry as it had been initially, and it's just moderate pruritus, excoriated scaling papules. And then in the chronic phase, where it's more thickened skin or lichenification, and then you have these fibrotic papules. And in one patient, these will overlap. We'll have these chronic things and then with like acute presentations on top of it. And so as the patient ages, the clinical features also change. So in infants, you'll have more pruritic, red, scaly, crested lesions, more vesicles. Initially, it'll be more in their cheeks and scalp, and they're in the extensor surfaces. Pretty much the areas you would think about when they're crawling, a lot of friction is going to cause a lot of damage to their skin. It'll spare the diaper area, so if you see it going into there, we have to start thinking about other things. And then serous exudates and crusting if it's severe. In childhood, as they get a little bit older, you have more flexure involvement, more infragluteal area is very common in these kids. And then you'll have more scaling papules now, and then less exudate but more lichenified papules or plaques. And in adults, it's more flexure again. These are, since the disease has been around longer, it's have a more chronic presentation. So it's going to be lichenification, excoriated fibrotic papules. And in the adult patients, they'll commonly have an increased risk for developing hand eczema. If it's their job, it calls for a lot of hand washing or like putting their hands in wet water a lot, they'll have more of this hand eczema presentation. So here's some pictures. This is, young, it's an infant. You'll see the red scaling, some exudate on their cheeks especially, and their chin as well. And they just, he looks uncomfortable. And then as time goes on, so we have some more flexure involvement. This would be more of a subacute presentation. You'll see some of it looks like it's dry and it's pruritic, and some of these erythematous papules. And then this becomes more chronic. I don't think it's coming up quite as well, but basically you have this scaling, and it's more lichenified in the flexure areas again. So why is this important to us? It's important because it affects 10 to 20% of the children that we see and 1 to 3% of adults. And it's really sad if you talk to your patients, they'll say, a lot of them, that they're getting bullied or teased at school for this. So 60% of school-age kids do get bullied for this. And you'll see, like, I've had patients, they'll like put their sleeves over their hands just because they're so embarrassed. A lot of times this also leads to behavior and discipline problems. They'll have excessive dependency, hyperactivity, and they'll start scratching just to get attention because they're so used to it. And if you can imagine, you know, if they're scratching through the night, they're not sleeping well, they're going to have that's going to lead to more daytime behavior problems and discipline problems. And if the babies aren't sleeping, the parents sure aren't sleeping either. So the parents are going to be deprived from sleep and exhausted, and just the ramifications of that for their work and productivity. And it leads them to have this pathology where they're itching throughout the night, and they kind of have difficulty, even when their atopic derm clears up, they tend to still have difficulty sleeping at nighttime. Parents start developing this anxiety and prefer to have social isolation, so they tend to not to like go to church or family functions as much, to keep their kids protected as much as they can. And in one study, they compared the impact of atopic dermatitis to insulin-dependent diabetes on families, and they found that this will in fact impact families more than the diabetes would, which I thought was really surprising. So I think we're all familiar with this, the atopic march, and it's important because atopic dermatitis is usually one of the first manifestations, and these patients go on to develop more atopic disease as time goes on. So if you look here, we have age on the x-axis, and so atopic dermatitis starts pretty early on, that has a higher incidence earlier on, and then food allergy coincides with this because a lot of times these patients do have a food that's exacerbating their dermatitis. And then, you know, around 2 or 3, you have asthma starting to pick up, and then later on, these patients tend to develop allergic rhinitis as well. So the pathogenesis, there's 2 ways to think about this. It's the outside-in theory and the inside-out theory. The outside-in is thinking that there's outside environment or irritants or allergens that's irritating the skin, causing them to develop atopic derm. And the inside-out is that there's something inherently wrong with the skin that's allowing them to develop this disease. One of the big things that's important in our skin is the permeability barrier. And in these patients, for various reasons, their skin is more permeable, and so the irritants and allergens from the environment permeates through the skin and causes them to react to it more than a normal patient would. And also with this, since things are getting in easier, they're also losing water faster. And so these patients have an increased chance of epidermal water loss, which is really important to having an intact barrier. And a lot of times you'll see the faster they lose water, the worse their disease is. And this is what's contributing to the itch-scratch cycle. And you'll hear about this a lot in some of our literature, where it says that these patients, the more they're itching their skin, the scratchier it gets, and it's kind of this bad cycle. And so we try to stop that. And one of the big things is moisturizing their skin to keep it nice and moist and keeping the water in it. One of the first mutations they found in some of the atopic dermatitis patients is the filaggrin gene mutation, and that also plays a part in keeping the skin intact and as a good barrier for our immune system, basically. These patients also have a pro-inflammatory atopic response, why they react to these irritants and allergens the way they do, and that's part of the atopic march for them as well. It's initially a Th2 response, but then as time goes on, this becomes a more chronic disease. You'll see as well a Th1 and Th2 response. And for various reasons, they do have a reduced cutaneous antimicrobial activity. So that's why you'll see more infections in these kids, more molluscum and like herpes infections as well. Part of it has to do with as their Th2 is driving up, they're less likely to be able to fight off these infections. So this is just a picture of a patient that actually does have the filaggrin gene mutation, and you can see their palm has hyperlinearity, and so that's just something when you're examining your patients and you look at their hands, you might see this on their palms. So the microscopic findings, if we biopsy this, what are we going to see? So, and even non-lesional skin where it looks normal to our naked eye, they're still going to have an inflammatory cell infiltrate, and they'll have some spongiosis as well. And the acute lesions, we're going to have some intraepidermal vesicles continuing to have the spongiosis, and then in the dermal inflammatory cells, you're going to have more lymphocytes than monocytes. And as time goes on, it becomes chronic, you're going to have hyperkeratosis, you're going to have more Langerhans cells, more mast cells, And then here the pattern's more going to have more monocytes and macrophages than lymphocytes. So the role of allergy in this, 80 to 85% of these patients have an elevated IgE level, and typically it correlates with how severe their disease is. And what's interesting is that these patients also develop specific IgEs to multiple foods, inhalants, and also the Staph aureus toxin. So these are enterotoxin A, B, and toxic shock syndrome toxin 1. And so this basically means that even independent of infection with staph, these kids are developing IgE to the staph toxins themselves. So just even having it on their skin, as many of us do, they're irritated by that. A third of these kids have clinical reactivity to a food allergen. Most commonly it's hen's egg, and so that's why we like to skin prick them to see if they do have this food element in their atopic derm and help them with that. And then chronic exposure to the food allergen leads to these typical eczematous lesions. A lot of times it's really hard for families to see what food it is because they're eating it on a regular basis, and the eczema is chronic and it's ongoing, so they can't pick up like this one time they ate this and had anaphylaxis. It's completely different. And it's important to know that sensitization and allergic reactions are different. So while they may have a positive reaction on a skin prick test or positive immunocap, how that clinically relates to the patient is different. And we'll go into that a little bit more detail here. And recent literature has shown there's an increasing role of aeroallergens and air pollutants worsening atopic dermatitis as well. So identifying food allergens. So you want to first have a good medical history, as always, and then you want to have maybe a food or symptom diary so that they can look back and be like, they ate this for lunch, and around dinner time their skin started to flare, and trials of elimination diets. If eliminating, for example, eggs from their diet will make a difference in their skin. And our screening test that we use is skin testing, and it's important to keep in mind a negative skin prick test has a negative predictive value, meaning that if it's negative, it's most likely not going to be a culprit in their atopic derm. But if it's positive, we kind of have to correlate it with their history and how the patient does, maybe on an elimination diet. Serum-specific IgEs, and then keeping in mind to use the 95% predicted decision point for milk, egg, and peanut have been useful. And then you always want to verify this with an elimination challenge, like we said, to see how they do off of that food. And so how you proceed with that is you eliminate the foods for about 1 to 3 weeks, probably closer to 3 weeks, to really give it enough time, and since this is like a chronic disease. And you want to document improvement in their skin while the intake of medication is minimal. You can consider doing a supervised oral titrated challenge in the clinic to see, how their skin reacts to the food after starting it again. And if it's multiple foods, as commonly it is, you want to allow a few days in between these challenges to actually give the skin time to react, and so you don't get confused, was it this one or that one? Consider placebo tests, especially if there's a psychological component, and you want to document the recurrence or exacerbation of symptoms. And keeping in mind that there's a biphasic response or reaction that can initially will start within 15 minutes to about 2 hours, and the later reaction will start several hours later, and it can go on for 1 to 2 days. Now, how to treat atopic dermatitis, which is probably why we're all here today. It has these 4 pillars, and so it's anti-inflammatory medication, moisturization, and antibiotics, and antipyretics. And so for antipyretics, here we like to use antihistamines typically. In our younger kids, we'll use sedating antihistamines, and we tell the parents to schedule these either twice a day or 3 times a day, depending on the child, for weight-based dosing, and to tell them to take it all the time so we really break through that itch-scratch cycle and to allow them to get some relief, to stop scratching and give their skin some time to heal. And also, we advise against topical antihistamines just because that can further fuel the fire and be a further irritant to their skin. So the things to keep in mind when treating these patients, you want to first make sure that you're doing everything, just the fundamentals of therapy, before calling them a treatment failure and escalating therapy to the agents that Dr. Bahna is going to talk about. Also, you want to review the irritants, the allergens, infectious agents, and emotional stressors with the family and the patient. And keep in mind that every eczema is different. Just because one thing may work for one patient, you have to always have an open mind to know that another patient may actually not react well with that cream or with this type of approach. One of the biggest things is to have a correct prescription size. So sometimes we're prescribing these ointments and we don't really look how big it is, but it's like this big of a tube for their whole skin, and they're like, I ran out after a week, and their skin's just perpetually getting worse. And so always try to keep in mind how much of a body area you're trying to cover for how long, and to put that into your prescription. And knowing that skin barrier defects leads them to have this increased chance of epidermal water loss, they have a reduced water binding capacity, and so with that their ceramide levels are also low. So moisturization is really so important. And the most important thing about moisturization is that the best one is the one that you're actually going to use. So, you know, if we're trying to say use this, and the family are like, well, we really don't like that, or we want to use another one, whichever they feel the most comfortable with and they like the most and have the best experience with is the one they should use. This was, they looked at these different moisturizers starting with Vaseline, Aquaphor, CeraVe, down to more expensive like Episerum, and they looked to see how expensive these were per ounce. And if you look, Vaseline is 35 cents an ounce, Aquaphor is $1.21, but some of these is $27 an ounce. And I don't know, my patients probably would not be able to afford that, and I can't be unrealistic with them and tell them to use these. When in all this, I mean, studies have shown that Vaseline is just as good as they are. And so recommending these other these other moisturizers that are more cost effective for our patients is really important. And so for the anti-inflammatory arm of treatment, our first line would be topical corticosteroids. And we like to recommend this for our patients. It works really well. A lot of times you might see that some patients have this steroid phobia where they're nervous to put steroids on their baby's skin. But a good way to get over it is to say that this is cortisone, or cortisol, which is something our body makes itself. And we, in this acute period, are going to help our body to heal. And to help them think that putting this on their skin is so much better than the oral steroid regimens that we sometimes give them. So if we can prevent oral steroids, then that's the best thing. You always want to weigh the risk versus the benefits. And once they're controlled, we want to do what's called a proactive approach versus reactive approach. So once their skin is doing great, you can consider putting them on 2 times a week for maintenance therapy, just to keep their skin at bay and from having like dramatic recurrences. And then the topical calcineurin inhibitors, and we'll talk about these more specifically, but the benefits of these overall is that it doesn't cause skin atrophy like long-term steroids can. It can be used on the face, eyelid, and skin folds for kids greater than 2, and it has a lot of pruritic relief. The disadvantage is that you'll see some transient burning, and that's more with the tacrolimus usually, but it can still happen. And then some patients will be worried about the black box warning for carcinogenicity, but that was more in preliminary trials, and they looked back on it, they found that it wasn't any higher than the population. And like we talked about, the proactive versus reactive therapy. There isn't good literature for this, but some anecdotal evidence, and for cutaneous lupus they did this, where they used topical steroids in the morning and topical calcineurins in the evening, and they found that patients did really well. So in the community, you might see this approach sometimes. So talking about tacrolimus, otherwise known as protopic ointment, it's given twice daily, and it comes in 2 different strengths, the 0.03 and the 0.1. Typically, 0.03 is used for 2 to 15 years of age, or is approved for that, and the 0.1 is used for greater than 15 years of age, and you want to continue it for 1 week after resolution. And this is an immunomodulator, so this is affecting the immune system or the immune cells at that location on their skin. So it suppresses this T-cell activity by kind of shutting off the transcription for some of the pro-inflammatory cytokines. It has minimal systemic absorption after applying the 0.1% strength, and it can cause some burning sensation. And in these patients, we want them to avoid the sun. And keep in mind other medications that they may be on, so erythromycin, cimetidine, and ketoconazole can interact with this medicine. In these patients, if they do have eczema herpeticum, zoster, simplex, or herpes simplex, or EBV infections, you don't want to use it on top of that, so keep that in mind. And then pimecrolimus, or otherwise known as Elidil, it's similar to tacrolimus. It's approved for ages 2 and up. Some studies have shown efficacy down to 1 year of age. Again, minimal absorption, low potency. This one can cause less burning sensation. In my experience, insurances don't approve Elidil until they've failed protopic. So antibiotics. Obviously, you want to treat them if they're clinically infected, if they're oozing, like if they have crusting or exudates. Other approaches would be to use dilute bleach baths, and we'll talk about how to do that here in a second, and intranasal mupirocin. For both the patient and the family member if you're trying to eradicate staph from them. And so you want to do it intranasally twice daily for 5 days. And that gets rid of the staph, which then gets rid of the IgE response to their toxins. And that's the theory behind that. To make the bleach baths, you tell your patients to dilute a cap full of bleach into a water-filled bathtub. And so it's just a little cap of the bleach, fill it up, put it in the bathtub. I know some people are worried about it having too much chlorine, but it's less chlorine than in a pool, so it's pretty safe. You're going to use it 2 or 3 times a week. Make sure to rinse afterwards. And they've done studies with the bleach baths alone, and they found that there's a significant decrease in the eczema activity and reduction in the Staph aureus density after 2 months. So it's really effective and a really great tool for our patients. If you want to treat their food allergy with their atopic dermatitis, you want to avoid obviously the food. You can do some elimination diets. If it's an infant and they're on formula still, you can use an elemental diet, so Enfamil, Neocate, are elemental, so they wouldn't have reactions to this. And if you could try also the extensively hydrolyzed. So these are not non-allergic, but rather hypoallergenic formulas, and this would be Alimentum and Nutramigen. And this would always be in the setting in conjunction with skincare regimen and pharmacologic treatment. So if you have a patient with atopic dermatitis and you're treating them and they're doing all this stuff and they're not getting better, you might have to think, is this something else that I need to be worrying about? So some of the other things that we probably come across more in the peds clinics or might be the primary immunodeficiencies, so the hyper IgE syndrome, which overlaps a lot with atopic dermatitis. It's severe atopic derm, recurrent infections. These kids will have, if they get older, have primary, retained primary teeth, sometimes they'll have scoliosis, and their faces will just look coarse faces. They'll have a different look to them. Other things would be Wiskott-Aldrich syndrome, and then SCID, which is a lot more rare, but it could be a presentation of that as well. Other things, we would also say like Netherton syndrome sometimes. Some contact derms can mimic atopic dermatitis. And things that I don't think we think about common enough is like vitamin deficiencies or mineral deficiencies sometimes can present, or similarly to atopic dermatitis. So the Eczema Action Plan, we started instituting this in our clinics, and it's similar to the Asthma Action Plan, kind of giving the patients a tool for what to do if their skin gets worse, and to have it written down for them so they know what they're supposed to be doing for their child's skin on a daily basis. So it's individualized, there's areas for you to fill it in. It kind of gives the benefits and risks of medications, where to put the medicines on them. I mean, I can't tell you enough times where they're like, oh yeah, I put it here, and they have eczema like everywhere. I'm like, oh, we need to broaden this a little bit. How long to be using these medicines, recognizing their exacerbating factors, and adjusting treatment based on their severity. So if they're flaring, they know that they can use this stronger steroid until they get in touch with us. And it makes, they've done studies using the Eczema Action Plan, and patients have been more comfortable about their treatment plan and less anxious about treating this at home. But also in the studies, I found that there was no difference in understanding what eczema was or their ability to recognize disease remission, which makes sense. Both groups can say their skin looks clear now. So this is an example of an Eczema Action Plan. It kind of first defines what it is, and that there's no cure, and then instructions from your doctor. So this would be where you put like the foods that you would want them to avoid, and then some tips. So bathing daily is key for these patients, mild soap, patting the skin dry, moisturizing. And I like this here because it gives them a list of moisturizers they can pick from so that they're not going to the supermarket and getting super confused. And then fragrance-free soaps, and definitely no dryer sheets. And on the bottom part, it kind of says like what to do in a flare-up, what medicines to use, call the doctor here. And it has like, just like the Asthma Action Plan has the green, yellow, and red, this has a similar thing. So green is your normal, yellow, you're mild, pink is moderate, so some bad itching, they're having some trouble at nighttime, and in here it's written it in, but the one that we use in our clinic, we can write in what medicines we're using. And then for severe skin, it's, if it's really bad, go ahead and call your doctor. And then another tool for our patients is wet wrap dressings. They've done a study with about 200 patients where they did wet wraps for about 4 days, and they noticed that 90% of them had more than 50% improvement, and most of these patients had more than 75% improvement. So their skin got dramatically better in just a period of a few days. And what you want to do is you want to bathe daily, and then you put your steroid cream on, and then you could do a moist gauze, or sometimes old pajamas we'll say like make it a little bit moist, wring it out, put it on over the medication, and on top of that, you would want to put on just dry pajamas and put them under warm blankets and keep them warm overnight. And it helps them not only because they can't get to the area, they can't scratch it, but also keeps the medicine and helps it penetrate better and keeps them more moist. And then the Una boot also is something that could be used for atopic dermatitis. This is what comes in this white gauze, and it's moist, and it's with calamine and zinc oxide, and so you would wrap it on the affected areas, and then you can use like an ACE bandage over it to kind of keep it covered. They haven't done studies with this with atopic dermatitis specifically, but they've done it for other like venous ulcers, and patients have done really well with it. So it is a tool if we get to that point. And so just to kind of wrap up, at least my section, treating atopic dermatitis is as easy as ABC. Keep this in mind. So A is avoidance of the triggers, whether they're irritants or proven allergies. Kind of educate the patients about that, and let us know if we can help with the allergic evaluation in these patients. And then barrier repair and maintenance would be the B part of it. So really important to keep them hydrated and moisturized. A lot of these patients, if they moisturize regularly, they can come off the steroid ointments pretty much completely. So you want to address the itch cycle with that, with medication, behavior. Consider wet wrap therapy if needed. And then C is control of inflammation and infection. So be using a proactive therapy, using culturing their skin if you're worried about eczema herpeticum, using antimicrobial agents, and using corticosteroids and topical calcineurin inhibitors appropriately. And that's it from my part. I'll pass it on to Dr. Bahna here, and so he can give you a little bit more information about the advanced medications available in our in atopic dermatitis.
Thanks, Hannah. You did a wonderful job. I don't need even to stand now after your good delivery and nice voice compared to me, but that's good. I'm proud of you. The atopic dermatitis or eczema is a common problem, as you heard. In general pediatrics, a large number of it. It's frustrating. Anything that appears on the skin is frustrating to children or adults, and more to the adults and young infants. The baby poor baby does not have anything to do, but the parents are irritated. As you heard, about 50% of it start in the first year of age, and by 5 years, 90% of them started. And in the first year, most of them in the first 6 months. So it is an unhappy event. Babies are always born with anticipated joy since the time of pregnancy. And they are preparing cameras and videos to take pictures. And when the skin has something, all this is just hindered. Visitors, they are trying to hide the baby. The impact of psychology in the family is remarkable in this. So we have to discover it early and deal early to avoid or minimize complications in that. The plan that Hannah mentioned is very effective, and most patients will do well on it. Patients has to know that this is a chronic disease. It is not an infection that we do with antibiotics or surgery. Most of them will prefer, in fact, do surgery and get over with this than to leave it there. So I'm going now to talk about the recalcitrant, the severe asthma that we see a lot of there. And we get it from you in the pediatric clinic, and welcome. Sometimes even you come to us while during our clinic, and we go to you there on the spot to help you in the diagnosis and in the management until we see them. So it would be a good bedside teaching with you right away. Don't be shy to come to us if you have the patient already in the clinic. Then why this atopic dermatitis is recalcitrant? I guess Hannah mentioned, is it atopic dermatitis? Not every eczema is atopic dermatitis. Eczema is a manifestation like a person has cough or has wheezing, has headache. So what is the cause of the eczema? Is the management appropriate and being followed? Being followed is very important. Many of our patients are unfortunately not compliant. And they're compliant with the pharmacotherapy. Some of them, they take the medicine, but they don't spend the time for the skin care or the dietary elimination. Infection is a common problem here. Staph, fungal. The antimicrobial peptide that's normally present in normal skins is lacking. And staph take advantage of this. Atopic dermatitis patients have a Tcell defect. So fungal and viral infections will happen. And herpes simplex is a common one of them to spoil the whole setting. Then constitutionally, sometimes we believe that the parents are doing their job and we are doing our job, and the patient is constitutionally severe. We have yesterday a child, the mother was crying. She has been going from one dermatologist to the other, allergist to the other, and she just say everything is not working. We discovered some reasons that which is difficult to solve, because the Medicaid will not approve some medication that I will explain now. And when we offered, we will talk to the Medicaid to convince them. The mother said, but I am very concerned about poisoning my child. She mentioned that exact word, with medications. In the meantime, say, do something. So spent a long time for her, and the emotion was that bad that I took her out of the room and the fellow with the child in the room, so that I counsel her that this heavy emotion is worsening the situation. To a degree that the girl became now complaining of anything to be put on her skin, even when the fellow there put a very bland thing from the tube in the clinic there, I think it was Vaseline or something in there. Very mild thing. She just put a little, and the girl said it's burning. So psychologically, she has been soaked, and anything will be harming this child. That's a big factor. So I'm going to talk first, before medication, the role of these two, which is the diet and the staph, which I think the most neglected, although they are the most important factors if we do them. Hana mentioned them quickly, but I will just give very little one. This patient we saw in another institution before I came here, came without much history and looked like coming out the whole body, like coming out from an oven, from a fire. So the differential diagnosis was difficult. What is this? We didn't see the patient before. This picture was taken after sedating the child markedly so that he can be resting a little bit, because we could not touch him or draw blood or anything. So we're afraid to give steroids. That might be an immune deficient patient. Is it literal seaweed disease? Is it what there? What is it? Well, let us try elimination diet and antibiotics now without steroids, and give antihistamine, sedate. And they stayed in the hospital for a few days. And we did not give systemic steroids. And look at the marked picture, emphasizing how can eliminating the cause. We didn't know the food yet, but we give elemental diet that is a hypoallergenic purely, and we can make a big difference until later on we sort out the exact foods that can be 1 or 2 or 3. So to emphasize again, family want us to do the thing, but don't put burden on me. Don't tell me what to do. I have many children and I cannot avoid these things, and it's hard for them, but this is really an important treatment. Staphylococcal infection is common and can spoil it. It doesn't have to be obvious pus or oozing. It has a decreased antimicrobial peptide inviting infection. Staph aureus is present in 90% of patients, either colonization, just with the skin looks all right, or active infection. We don't have to culture. The treatment is faster and cheaper. Infection breaks the skin barrier. Already the skin is not good to start with. Scratching because of the infection also disturbs the barrier. Staphylococcal extoxins play a major role. These extoxins, and I hope I'm not confusing you with the terminology, enterotoxins are exotoxins. We're not talking endotoxins. Enterotoxins are part of the extoxins. Toxic shock syndrome, number 1, is part of the extoxins. So this group of extoxins act as allergens like egg, milk. So there's antibodies to them. Enhance the expression of CD23 B cell that whatever it produces of anti-food will produce more of it. And then acts as super antigens, means induce directly the T helper cell that pushes the B cell also to produce more. So this has a major role and frequently neglected. When everything is done, give a course of anti-staph, usually erythromycin or Keflex, cheaper than other stronger ones first. Methicillin-resistant Staph aureus is more than 1/3 of the hospital admissions with staph infections or MRSA, 50% or more. Some major pediatric hospitals, this is a very bad organism. Most community-acquired MRSAs are sensitive to trimethoprim sulfa, rifampin, gentamicin, and other, but we go with the cheaper first. If we fail, we go up. Eradication of carrier state, as Hana mentioned, either in the child or in the family as well, become reinfected again. Our wonderful instrument that we move it from one patient to the other in the hospital is a good collector. So if you just have alcohol swab and you clean it, I assume that you are washing your hands between patients. And patients, by the way, respect that mark, they're very observant. I was praised when the family saw me washing my hands in front of them before examining them and said, "Oh, you are the first doctor." Oh, I just felt good. But I wash the hands after I examine the patient before I leave, so that they see it, and before I examine the patient next time. So they have a chance to see that dog. And the patient just very observant about it. There are some patients, some parents are refusing, not refusing it. I mean, they just don't stretch their hands when I shake their hands. So we don't. Why are they doing that? Fear of infection from our hands. And I smile and say, that's all right. Fungal infection. When you see a patch with segregated edge, active edge, and that's a Tcell defect in the atopic dermatitis patients. When you see that, try with topical antifungal unless it is spread markedly to go for systemic. Certain organisms are more, other, the newer now would be Malassezia than the older organism. Pyrosporum can also act as an allergen, specific IgE to the fungal, and the oral ketoconazole or itraconazole will be helpful if there are many patches severe. Another infection is dermatitis herpeticum, again Tcell defect. When you see vesicles like that, so suspect that, you may take to prove it with zinc smear, and many times we treat it empirically. We don't wait for that. Acyclovir will be needed. Bioavailability of oral acyclovir is poor, but oral valcyclovir may be better. And for recurrent infections, oral acyclovir will be given. Some resistance can be present. Well, alternatives for the resistant will be other reagents. And this is one of our patients here that just asked the fellow to take serial pictures, admitted. That's at the time of admission. Very bad, particularly when it's in the face and around the eyes. After 12 hours, there is some improvement. After 24 hours is more. 2 days, 4 days, and here 6 days before went home. And he compared the two pictures, treated. Very impressive to the family. If we do all this, no infection, we treat infections, and the diet is done, and to the best of the family's compliance with it. But the compliance is a big issue because it needs care every day. There is some misuse of the medications. The easiest of them is antihistamines. They think use antihistamine when needed. In chronic allergic diseases, please don't mention when needed. It is needed. You don't wait. Say, when you itch, I'm giving one dose. I say you just like you have the car, you put gas when it stops on the highway. Oh, really? Yes, yes. You have to put gas before it stops. The diet. So I'm doing my best. They don't see organisms and they know the major effect of infection of something don't see. Minute quantities of allergen in some patients can be of great negative effect. So what else, if we did everything, what else we can do? Systemic immunosuppressants. Allergic diseases are hyper reaction in the immune system, going in the other way, going to act against normal, benign things we eat or around us. So we need to inhibit that fight. Cyclosporin, azathioprine, methotrexate, mycophenolate, these are various immunosuppressants, and we'll go them one by one to find one that's suitable. And all of them have side effects, we have to monitor it very well. Some investigational or off-label immunomodulators, IVIG, anti-IgE, recombinant interferon gamma, and a new operation still in investigation, anti-interleukin 4 receptor 1 alpha. We'll go one by one in these. Cyclosporin for severe atopic dermatitis. Many trials have been done and showed it is effective. The dose, 2.5 to 5 milligram per day for several months or a few years. The improvement starts within weeks. The lady of yesterday said we tried cyclosporin for a month, it didn't work. She was not told apparently that it takes many months. And the mother was a pediatric nurse, so she reads. And she tried to control the management of the patient, which made me brag, sort of. I have to say, in my 40 years of treating atopic dermatitis, your child has about 4 of 10. And it's not severe. Oh, she was displeased to hear that I said I am for 40 years. She doesn't care about that. She cared, I want my child to be done well. And then I said, we have to give cyclosporin for many months or even a few years. She said that Medicaid does not approve it. I said, we will do our job. No, but I don't like to poison my child. It was a long time tough yesterday with this lady. But they have to know that from the start. Monitor blood pressure because of the renal effect of cyclosporin. We have to watch for that. And the relapse occurs even after 4 years of treatment. The immune system, I did not change it. I did not give bone marrow transplant for that. So the problem is there. Azathioprine may try in patient unresponsive or intolerant cyclosporin. Dose is very similar. Duration few to many months again. This is not a course of antibiotic. The onset of improvement within 2 to 6 weeks. Many patients quit after a week. After 2 weeks, say that's it, it's not working. Side effects, we are monitoring them, take a baseline and we continue bringing them. It's not easy for these children to draw blood from them. Document the pre-treatment normal thioprine methyltransferase level because it is needed to be present to work on the azathioprine. But it's a deficiency. If this enzyme is deficient, leads to accumulation of toxic substance and metabolites that cause suppression of the bone marrow. We tried, this is one of several patients that are severe. I didn't have the pictures when she was very bad, but she has been with us for several years. And we tried everything after dermatologists also tried everything and they sent. I was pleased with the dermatology community that they are referring to us severe cases. They acknowledge that we can help their patients and they are very pleased when we reach that stage. So this, we gave cyclosporin A before, didn't work well, partially. I will follow with azathioprine, and you see this picture here. I don't know, fellows, if they have earlier picture of this patient that you can compare with, but this is a remarkable improvement. Methotrexate, another immunosuppressant, it is a folic acid antagonist with anti-inflammatory effect. Therefore, since it's antagonist, we have to administer folic acid as well. And we start with a smaller dose, 5 milligrams. This dose then gradually will go up in it to the appropriate dose, not exceeding 25 milligrams per kilo. May start to improve within 2 weeks to 3 months. If no noticeable improvement on 15 milligrams for 3 months, unlikely to respond higher, so just switch to something else. Again, they have side effects, GI, the liver, myelosuppression, hair loss. And we have to say this up front, and many patients just refuse it. I don't want that. They don't want that, but they want us to find something doesn't have any side effect. I would say there is nothing, doesn't have side effects. And we enter into longer discussions until I say, ma'am, I'm not hiding it in my pocket from you. I'm not selling drugs. I write the best drug that is available, but everything has side effects. And they may prefer not to use it for that fear. Investigational or off-label therapies, since we are a tertiary care center and the colleagues, whether allergists or dermatologists, expect some help, sometimes we cross the line and we don't follow the PDR, but we follow research and publications. So we can go off-label. IVIG is an immunomodulator. It's not used for immune deficiency in these patients, but it does wonderful things that you cannot explain every good action of IVIG. But it's not approved and very expensive, and it's going to be for a long time. So we tried very hard with the insurance, and we succeeded with one patient. Didn't succeed with another one. They just wasted our time back and forth. I talked to the medical director, and the medical director is a family practice physician. I talked with him with great respect, and I said, I am now here This is one of two minimum number that I request these things in. I am with the patient who's costing for you a lot of money by admission to the hospital, does not go to school, making a lot of poor family dynamics. And sometimes I succeed, most of the time I don't. And sometimes I like to talk to a specialist. So they give me a specialist. With these things takes a long time, by the way, to arrange all this. And then I get a rheumatologist, actual rheumatologist. I said, well, good, you are close enough to me. I said, I will write my recommendation, but you know, I'm not that decisive. Meaning administrators are taking medicine from us. They tell us, no, we will not allow you to do that. Very unfortunate. No. Anti-IgE. IgE has a great role in atopic dermatitis. It has the highest level of IgE of all allergic diseases, except an immune deficiency which is called hyper-IgE syndrome. So we tried that anti-IgE in a patient also, although it is not approved for that, it is for asthma, and recently for chronic idiopathic urticaria. Recombinant interferon gamma has a lot of side effects. They just feel like they have the flu all the time, and they don't like it at all. A new preparation still at phase 2, just the information appeared in a recent meeting in the Netherlands. So IVIG has immunomodulatory effect. Scattered reports showed efficacy, but it's in a high dose. 2 grams per kilo, that's a very expensive stuff, monthly. Efficacy is more in adults. Again, not approved for that, but we fight as a specialist and we break the rules. This is the example of that girl. She had 3 months atopic dermatitis, managed by excellent dermatologists, with suboptimal improvement, generalized severe eczema persistently. Every time it improves, the IgE level goes down, and when exacerbated, it goes up. And this is very high in the sky. Very good compliance with medications prescribed by the dermatologist or later by our allergy clinic. The parents were very good. Slight response to skin care, topical corticosteroids, tacrolimus, oral antihistamines, and frequent course of systemic antibiotics, which she tried hard not to because it improves quickly and rebound can happen. And parents who liked it, they push us. It will not improve without steroids. They push on us as if, don't you understand? I need steroids. We try to talk about the side effects of them, and some of them will start because they get it from other sources. We like to cook the patient. I'm sorry, cooking the patient this, but work on the patient slowly rather than quickly to burn the patient and be happy with that. Frequent courses of systemic corticosteroids brought modest improvement. This girl in particular, she got osteopenia. We takes a scan on her. Other immunosuppressants were tried mostly by the dermatologist before us, off-label, or not approved even, but the dermatologist was frustrated. Used methotrexate, cyclosporin, azathioprine, other things for psoriasis even was used, other things for dermatologic or rheumatologic diseases were done. So all this is done by the dermatologist. Said, I did all what I could. And we tried the compliance. They were compliant. So when it came to us, we get a trial of IVIG. We're fortunate to convince the insurance, and the results in remarkable improvement, and discontinued after a few months, and she became fine. And the girl, this is not the worst. The worst pictures I could not find her because we saw this child initially in the hospital as if she is burned completely. We worked over her for a few years until we could not improve more than that. That was the best improvement by all what we have done until we added the anti-IgE. Then became like that. Completely different, happy. She was not happy to go to school. In the summer will not want to expose any part of her body, and you can imagine the impact of that. Look at her legs. Became a wonderful girl. The last slide is a new investigation, not just was reported recently in a presentation abstract, not in a paper yet. That is the antibody to the interleukin-4 receptor, which control interleukin-4 and interleukin-13 that drives the Th2-mediated allergic inflammation. The Th2 branch of the immune system is responsible for allergic disorders. In a 16-week trial, so 380 adults with moderate severe atopic dermatitis were randomized and were good improvement there. So always you start with adults and the children later, or pregnant women later, and trying the medications in them. So you see a lot of armamentarium. None of them is ideal, has side effects, a very high price. All this list that I mentioned to you are very, very expensive. A few months, a few thousands every year, every month, few thousand. So that's why the insurance don't want to pay this amount of money. So in conclusion, be sure it is atopic dermatitis. I learned this from a professor when I was medical student, and I transfer to you. It has been helping me today. He said, when you go out to practice and a patient comes to you and starting to say, I went to Professor X, tell him, stop it. Don't tell me what the professor said. He said, you take your own history and examination and you put your plan. Then you ask, after you compose your diagnosis and plan of investigation and treatment, what did the professor do and say? If you find that we are both agreeing, then we are right. If you find you are different, you are right. Because the patient came to me first, it does not help. It's a wonderful attitude. So practice this. We tended to read the reports, all of us do now, the reports of the patients coming from another specialist, and we pay a weight to the what's written and become influenced it, unfortunately. It's better to look at it after you make your own plan. The lady of yesterday, when I took the burden from the fellow and I was just really frustrated, I offered that can we take another opinion by an allergist or dermatologist. He said, I have been there in all of them. Can they can't be in all of them, can be one of them. Said, you choose. I said, if I choose that, if I call a colleague, he's going to tell you, Dr. Bahna is a wonderful, great person, he will be biased for me. So you just go without mentioning my name. He might have an idea I didn't get. Actually, I wanted just, sorry to say, that she moved away because we spent a long time with her and she was crying and crying. And I think there is a problem that I will explore. Why this girl is not getting better. I have experienced before about Munchausen's by proxy patients. This child is not in school, staying at home. And some patients who admitted them in hospitals, and the mother did certain things so that they be sick. So I am just having in my mind. Skincare, look the provoking factors, which is a burden on the family. Pharmacotherapy appropriate for the severity, emphasize compliance, the immunosuppressants, and the specialist can use off-label. We are more likely to be forgiven if we use off-label than a journalist does. And then monitor the sequelae of atopic dermatitis, because you heard that a cataract happens in severe atopic dermatitis and happens from systemic steroids. So it's good every year, maximally every 2 years, we have a slit lamp exam. If it is posterior, it is probably from steroids. And remember it, posterior from the word prednisone, PEP. If it is anterior subcapsular cataract, it's more likely to be from atopic dermatitis, AA. Yeah. Thank you. Oh, I took more time.
Thank you very much.
Any burning question that other people that arrive here?
Yeah, I think in the interest of time, we need to close grand rounds because it's after 9, but I'm sure that Hana and Sami would be more than glad to take any questions up front after the conference is over. So thank you all very much. Thank you for